think it's almost good evening, so thank you so much for having me today. It's a hard act to follow, these amazing talks, and I've learned a lot already myself, so I appreciate my colleagues speaking as well. So in the last closing talk this evening, I'm going to be discussing abnormal heart rhythms that can occur after aortic surgery, and actually after any heart surgery. Next, let's see, do I cue the slides? There we go. I have no disclosures for the purpose of this talk. So 3 main objectives today. One is to review how the electrical system of the heart works. It may be somewhat remedial for some of you, but I just thought we'd start with basics. Understand the most common electrical complications that may occur post-surgery, and then review treatments for these electrical issues. So just starting in a very basic way, of course, we know that the heart is a muscle and it pumps blood. And it's a schematic here just showing the left and right ventricle. And the valve that you see opening there at the top is the pulmonic valve. The aortic valve that we have been talking about a lot for the purposes of these talks is kind of behind and not shown here. In addition to pumping blood, though, electricity is very important to the function of the heart. And it may seem simplistic, but just as a building has an electrical wiring to make it have lighting and allow for electrical operation, our hearts also have electrical wiring, and that allows for signals that run the heart and the heart pumping. And so, I'm not sure, can I? Nope, I want to go back. Here we go. Let's see. Here we go. So if you start at the top, is there a way that I can use a pointer on here? Or no? Okay. If no pointer. So upper left, there's a little dot up there that we call the sinus node, nothing to do with these sinuses here, and that is what is governing most of our heartbeats, our heart pumping. That fires when we're at rest about 60 to 70 beats per minute. It goes to the upper chambers of the heart and they squeeze, as you can see. And then it goes down through this electrical bridge called the AV node and spreads to the bundle branches that go to the bottom of the heart, and then they squeeze. So it should go sequentially, upper, lower, upper, lower. And as you can imagine, you can get problems at any level of the electrical conduction. And so abnormal wiring, of course, can lead to abnormal heart rhythms. And there's just a schematic here showing the normal electrical impulses on the left and abnormal electrical impulses, in this case, atrial fibrillation on the right. Okay, great, thanks. So abnormal wiring can lead to abnormal heart rhythms, as I said. 2 major categories. One is slow heart rhythms, and so you can get slow sinus node function, you can get a block at the level of the AV node, or you can get block lower down in the conduction system, all causing potentially slower heart rhythms. So what kinds of symptoms would you have if you had fast heart rhythms or slow heart rhythms? So fast heart rhythms can be actually asymptomatic. Some people come in and they have no idea that they're having a fast heart rhythm, but in the people that feel them, they might feel what they call palpitations, which is a nonspecific term for just a fluttering sensation in the chest. They could feel fatigue, lightheadedness, chest pain even for fast heart rates, trouble breathing sometimes, and sweating. For slow heart rhythms, most commonly, and again, people can be completely asymptomatic even if their heart rates are super slow, but for slow heart rhythms, people can have fatigue, lightheadedness, or even faint. So there are specific risk factors for abnormal heart rhythms that we identify, actually not that dissimilar to some of the other aortic syndromes, but they can also happen in young and healthy people as well. But as we age, of course, risk factors increase because of scarring that can happen in the electrical system, just like anywhere else in the body. But in addition, high blood pressure, sleep apnea, coronary artery disease, lung disease, diabetes, and prior heart surgery are risk factors for electrical abnormalities of the heart. So, of course, one question that many of my patients ask is, are these arrhythmias dangerous? Is it a life-threatening condition? And the good news is most of them are not. Most of them are either a nuisance or otherwise very treatable. But some fast heart rhythms, if not treated in a timely fashion, can lead to heart failure, just because it's as though you're running a marathon for days and days or weeks and weeks, and that can lead to a decline in heart function. Atrial fibrillation is a specific type of fast heart rhythm. In some cases, some people are not that fast, but in some cases it can be fast, and it can increase the risk for stroke if you have risk factors for stroke. Slow heart rhythms can cause severe symptoms, like we said, fainting, and often do need a pacemaker. Some abnormal heart rhythms can actually lead to sudden death, although that's a very small minority of patients who have fast heart rhythms, and usually are seen in patients who already have heart disease. And abnormal heart rhythms that would put you at risk for sudden death are very rare after an aortic surgery or open heart surgery. So how do we diagnose abnormal heart rhythms? If you're in the hospital, most likely if you've had an open heart surgery or any type of cardiac procedure, you're on telemetry, depicted here. And we also, of course, do EKGs, which shows multiple electrodes showing different vectors of the electric signal from the heart. There are newer cardiac monitors, which I think many patients are enjoying much more than the old school Holter monitor, which was multiple electrodes. You had to carry around a box. Now the monitors, for the most part, are patch monitors, which are much more convenient, and actually even waterproof, so you can shower with them on. And there's a vast array of wearable technology that's incredibly helpful, I would say, for many patients to monitor their own heart rhythms and even sometimes diagnose their own abnormalities of their heart. I have many patients actually who've come into my clinic who have had a EKG-based watch and detected atrial fibrillation, and so very appropriately they come in to talk about what to do next. So what does all of this have to do with aortic surgery, you might ask? Well, slow and fast heart rhythms can happen after surgery. And in fact, between 5 and 60% of patients who have open heart surgery will get some type of an abnormal heart rhythm. Atrial fibrillation is the most common abnormal heart rhythm after surgery. But heart block, which is injury to the electrical bridge that I showed you before, can happen that can lead to either temporary pacing or the need for a permanent pacemaker. So just a brief word on atrial fibrillation, which again is one of the most common types of abnormal rhythms after an open heart surgery. It is the most common sustained arrhythmia in adults. About 13% of the population, by the time they're in their 80s, have atrial fibrillation. And even younger patients, 60s, about 4% of the population have atrial fibrillation. It is associated with very significant morbidity and mortality, and it can be quite debilitating for some patients that can lead to stroke, heart failure, or even death in some cases if it's not appropriately treated. But I always tell my patients, if you talk to 30 different people with atrial fibrillation, they're going to have 30 different management strategies, totally different symptoms. Some people are in the ER every time they have it. Some people have no idea that they have it. And so it's quite variable in its presentation. So what is atrial fibrillation? Unlike a normal heart rhythm that just has one impulse that fires, that spreads to the upper chambers, atrial fibrillation is basically an electrical storm in the upper chambers of the heart that is going about 300 times per minute, bombarding this AV node, and the number of signals that get through that AV node per minute is your heartbeat. And some people have an AV node that can conduct very fast, 150, 160, 170, and other people have an AV node that's a little bit more sluggish, which actually in this case may be helpful because then their heart rates are not quite so fast. So how about atrial fibrillation in aortic surgery? It can occur, I usually tell patients about 40% of the time, but it can range, of course. And the majority of cases happen in post-op day 2 or 3, so it's a pretty common arrhythmia. And it's typically transient. However, if you have atrial fibrillation after an open heart surgery, including an aortic surgery, you are at an increased risk of having atrial fibrillation in your lifetime. Now, of course, our risk of atrial fibrillation increases anyway as we get older, but if you have it, it's essentially showing that your heart has the ability to do this abnormal rhythm, and so it could happen in the future. But about 60 to 70% resolve in days to months. So risk factors for atrial fibrillation after surgery include increasing age, a history of arrhythmias, and actually some people may have had atrial fibrillation before their surgery and not even have known it because they were asymptomatic. Mitral valve disease increases the pressure and volume of the left upper chamber, which is where atrial fibrillation originates. Increased heart size, previous cardiac surgery, lung disease, diabetes, poor functional status, obesity, and alcohol abuse are all risk factors for atrial fibrillation. Operative risk factors for atrial fibrillation is really anything that's going to cause heart irritation, which is the way I think about why people get atrial fibrillation after surgery. So a longer surgical time or a difficult postoperative course definitely correlates with the likelihood of atrial fibrillation. So how do we manage atrial fibrillation? We think of A, B, C's when we think about management. A is anticoagulation or blood thinners to avoid stroke, and it doesn't include aspirin. Aspirin does not prevent stroke from atrial fibrillation. Better symptom control. Aspirin prevents stroke from other things, but not from atrial fibrillation. Better symptom control is B, and C, risk factor management or comorbidity management. So the short-term management of atrial fibrillation includes controlling symptoms, including slowing the heart rate, and we use medications that can slow the heart rate or stabilize the rhythm. You may hear the terms beta blocker, even calcium channel blocker. There are some specialized medications called antiarrhythmics, called sotalol and amiodarone that are fairly frequently used. Sometimes we do what's called an electrical cardioversion, which is putting a patient to sleep a very short period of time and then shocking the heart to reset the rhythm back to normal rhythm. And the goal number 2 is to reduce the risk of stroke and to prevent clots, and so putting people on a blood thinner if it's appropriate. The types of blood thinners that we use, I would say increasingly we use blood thinners that are not in the warfarin category. Warfarin's a medicine where you have to check blood levels very frequently and follow a fairly strict diet, and it's still an excellent blood thinner, but I would say there's more convenience for patients using some of the newer anticoagulants. So again, post-surgical atrial fibrillation is usually temporary, thankfully. And it can usually resolve within a few days, but sometimes it takes weeks to months. But up to a third of patients do get atrial fibrillation over time if they've had it before. So what do we do if they have more atrial fibrillation despite the healing phase after surgery? We have many medications that we use that can be quite effective at suppressing atrial fibrillation. And if medications are not tolerated, or if a preference is for a non-medical approach, we do something called catheter ablation, which involves putting IVs or sheaths into the groin and then placing catheters up into the right side of the heart, crossing over into this left upper chamber where atrial fibrillation originates, and burning rings around the pulmonary veins that have little electrical beats that fire and cause atrial fibrillation. So you're creating an electrical block. not to block blood flow, but to block the electrical beats that cause atrial fibrillation. So you're essentially making intentional scar. So stepping away from atrial fibrillation to the slower heart rhythm issue after surgery, aortic surgery can lead to heart block. And that is where the AV node, you're firing up here, but then the signal is not getting through. Why would this happen at the time of open heart surgery or aortic valve surgery? What you can see here is a schematic. Here is the aortic valve, and here is the AV node that allows the signal to go from the upper to the lower chamber. And you can imagine if you're cutting and sewing and putting in valves in this area, that you could cause inflammation, if not complete transection of this electrical conduction pathway. So the risk of heart block after open heart surgery is quite variable. We usually say between 1 and 15%. And of course, if you show signs of electrical conduction problem before surgery, you're more likely on your EKG, then you're more likely to require a pacemaker after surgery. But we see it usually immediately. If it's going to happen, it typically doesn't suddenly come up later on. It might come up chronically, but not right. If it doesn't come up right away, usually it's not going to be an issue immediately. Most cardiac surgery patients have a temporary pacemaker put on the outside of the heart and then coming out through the skin that can pace them if they need to, because it is such a common temporary problem after surgery. But not all patients who require temporary pacing after surgery need a permanent pacemaker, thankfully. And again, some occurrences are temporary. But persistent heart block or other types of slow heart rhythms that are symptomatic can cause the need for a permanent pacemaker implantation. And again, this is just another little schematic showing that the aortic valve is right here, and here's your electrical bridge that sometimes gets compromised by the placement of a new aortic valve. So what is a pacemaker? Many of you may know this already, but it is a device that treats low heart rates. It does not treat the fast heart rates, though. Patients come and ask me, can I get a pacemaker and that prevents my atrial fibrillation? And unfortunately, it might be part of the treatment for atrial fibrillation, but it doesn't prevent atrial fibrillation. Most types of pacemakers are about the size of the face of a large watch, depicted here. And patients ask me, are the pacemaker generators getting smaller over time? And unfortunately, the answer is no, because we also prioritize longevity of the battery life. We don't want to have to change your generator every year. So they're not getting super small because we prioritize longevity. So a pacemaker increases heart rates. Sometimes they just track the intrinsic impulse in that upper chamber that I mentioned so that it can pace the lower chamber in an appropriate way. But many pacemakers also have a little crystal inside them that can sense when you're moving around, and that will artificially raise or lower your heart rate depending on how active you are. Pacemakers also record any type of abnormal fast heart rhythms. And this is just an example of the kind of machine that we use to interrogate someone's pacemaker, and it tells us a lot of information about the rhythm, the efficiency of the pacing leads, and the longevity of the battery. So a pacemaker implantation is typically a minor procedure that takes about an hour. It includes 1 to 3 wires, and it has pretty minimal recovery period. For 1 month, we tell you not to do anything super vigorous with the side on which the pacemaker was implanted. We think of it as a low-risk procedure. The biggest risk is primarily the risk of infection because it's a foreign body. So we typically quote about a 1% per year risk for infection, which means that long-term, you have about a 5 to 15% risk of a complication from a cardiac device, including a device problem. So if you have a pacemaker, I would say it's very easy to live with a pacemaker. You can use a cell phone, you can use a microwave, you can go on an airplane, but you do need to get your pacemaker checked about 3 to 4 times per year, either in person or remotely. Most pacemakers now, you go home with a little monitor, either that you'd plug in next to your bedside, or actually there's an app for many types of pacemakers that you can just download to your phone, and that checks in with your pacemaker when you're sleeping in at night. But it is, like Dr. Mununga was saying, follow-up is critical because there are rare patients that are dependent on their pacemaker for their heart rate, and if you don't follow up and your pacemaker battery dies, some people are not able to be alive without a pacemaker, so there's some mortality risk if you don't follow up. The battery can last 8 to 15 years, typically, and the goal is that the pacemaker will not impact your daily functioning, and I would say for the most part that is true for the patients that I follow. So in summary, arrhythmias are common after surgery, and they can be seen about 1/3 of the time. Atrial fibrillation is the most common arrhythmia, but it typically does resolve, thankfully. But some patients do require short-term medications for treatment. And slow heart rates, including heart block, can happen as a complication of surgery, and sometimes a pacemaker is required. And I just wanted to say thank you to my partner, Dr. Pai, who put together many of these slides, and I'm thankful for that. So I'll end there. And I, too, am happy to answer any questions at the end.